Good afternoon, colleagues. Welcome to this week's deep dive session that is titled Lost in the Wake Up, South Africa's Missed Myeloma Problem. And it will be presented by Dr. Ryan Aylward and Sinead Quike.
Are you okay there, Honest?
I'm just looking for those intro slides because I see I'm going into their slides already.
It's on the screen. Um,
Maybe you can share that for me. I think that would be better.
Ryan, can you see the intro slides?
Yes.
Okay. Can you not see it, Honest?
I can see the title slide, but when I move them, it goes straight to the presentation, I think. Let's see. All right, good.
There we go. Got it.
So, yeah, by way of introduction, the deep dive management team led by the ever-able Prof. Estelle Verberg and the National Outreach Officer, Dr. Nicole Smith, and the administration being held by Mrs. Brooks. Right, a few housekeeping notes. Just note that all recordings are found on the website of the Blood Assay under resources, and you go to deep dive, you can get all the recordings there. And let's just mute ourselves during the presentations and feel free to add any questions or comments to the chat box, and these will be responded to at the end of the presentation. And when it comes to CPD points, all these sessions are CPD accredited, and the CPD points will be submitted automatically to the HPCSA for each registered South African attendee. And please just ensure that you are attending with your own registered Zoom link and not in a group so that you are able to get the points. And you need to have attended at least an hour of the session to get the points. Your HPCSA number must be entered correctly when you sign up for the deep dive. And if you have any queries or you'd like to request a CPD certificate for any other council or country, you may email admin@bloodsa.org.za. And if you want to join the mailing list via the website, you can just go to resources, subscribe to Deep Dive, or you can use the QR code that is shown on the screen. And every feedback is important to keep improving the platform. So Blood Assay and the speakers value your honest feedback, and please complete the anonymous feedback survey at the end of the Zoom meeting. So just to remind you of the upcoming events on the hematology calendar. So there is the Physicians Conference that will be held between the 4th and 6th of June, 2026. And it will cover most of the internal medicine topics, including hematology. And early bird registration is valid up to the 6th of March, 2026. And you can visit the website indicated on the slide there. And then there's the SASMO Success Conference that is set to happen between the 7th and 9th of August 2026 at the Central Convention Center. Early bird registration is also open until the 31st of March, and the standard registration runs from the 1st of April until the 30th of April, with late registration starting from the 1st of May until 31st of July. So hopefully a lot of us will be able to attend that. And then the Hem-Onc conference event to look forward to on the hematology calendar again, happening between the 2nd and the 4th of October 2026. I think it's happening in Cape Town, and it's being held under the theme Beyond Boundaries, From Progress to Access. Then next week, talking a bit of blood banking there, transforming and building Samba's donor base to ensure a safe and sustainable blood supply, a 20-year journey presented by Karen van de Beek. So today's agenda, we're going to be talking about Lost in the Wake Up, South Africa's missed myeloma problem, and presented by our two presenters. And then after that, we have a question and answer segment. You are welcome to post your questions in the chat box, and then that will be responded to at the end of the presentation. And I will hand over to you guys to start your presentations.
Good afternoon, everyone. My name is Sinead. I'm just going to start with a brief overview of our presentation. So we'll start with
putting up the slide.
Just putting up the slide. We're going to start with 3 case studies just to illustrate some of the main points of the talk going ahead. Next, we'll touch on the epidemiological picture of myeloma in Africa as a whole. Then Ryan will present some of the results of his investigations into delayed diagnosis and referral to our hospital here in Cape Town. And then we'll move on to our audience discussion. So our case studies, our first case is that of Mr. W. He is a 59-year-old male. He has a background history of gastroesophageal reflux disease, was previously successfully treated for TB, and has a heavy smoking history. So his presenting history or journey to diagnosis, he had initially presented to his district hospital. He had a history of multiple lower respiratory tract infections in the preceding months, as well as intermittent episodes of non-massive hemoptysis. On further history, he had also noted generalized bony pains, but predominantly in his limbs, as well as unintentional loss of weight. A preliminary workup showed a calcium and renal test that were within normal ranges. However, notably, he did have a mild pancytopenia at this point. His sputum TB testing and cytology were both negative for mycobacteria and malignant cells, respectively. He was subsequently referred to the pulmonology clinic at Groote for further workup of his hemoptysis. After noting an elevated gamma gap in his preliminary blood test, he had an after request that was made for an STEP and a serum-free light chain test. It is unfortunately unclear in this case if his results were followed up, and if so, how they were interpreted by the treating clinician. This will be discussed in the following slides. He was then seen again at the respiratory clinic in March, and the same tests for the myeloma workup were requested. Before he was again able to follow up with his respiratory team, he unfortunately sustained a pathological left femur fracture, at which point he was referred to the hematology team by his orthopedics team. He did suffer a rocky admission. It was complicated by hypercalcemia and a severe anemia requiring transfusion, and then developed sepsis requiring vasopressor support. So just to touch on the result of the initial SPEP that was registered. This was in November 2024. Just to note, the National Health Laboratory Service in the Western Cape has the authority to auto-refix immunofixation when deemed appropriate without contacting the requested clinician. So although the report notes a monoclonal band, there is a second band of undetermined significance. This output may be somewhat ambiguous or not clear enough recommendations for the next steps, especially if the clinician is not accustomed to interpreting SPEC results regularly. This here shows the serum-free light chain testing from November 2024. And then another potential issue that comes in here with the interpretation of the serum-free light chain testing is that one can clearly see there's an elevated level of free lambda light chains. However, the ratio reported is that of kappa to lambda, not involved to uninvolved light chains, and can potentially be falsely reassuring if just the lower ratio is seen by the treating condition. And then just again, the repeated duplicate testing in March 2025 showed similar issues and no change in the ratio. So just some learning points to highlight that we'll touch on later. So Mr. W's case here illustrates the importance in using an elevated gamma gap to prompt entertaining the diagnosis of multiple myeloma in the appropriate clinical context for the clinician involved. And then secondly, just a note on interpretation of SPEP results. So although the diagnosis was clearly suspected in this case, we can see this patient likely fell through the cracks, potentially due to misinterpretation of the SPEP results, and this results in duplicate testing and delays with this follow-up appointments being quite widely spaced apart. So we'll go now to case number 2. So this is of Mrs. B. She's a 74-year-old female. She has a background of well-controlled hypertension with no known target organ damage. So her journey to diagnosis, Mrs. B had initially visited a general practitioner in February 2025. She had an isolated bony right upper arm pain with no preceding trauma. She had received analgesia at the time, which helped for a brief period, and then returned to her GP in March with worsening pain, after which she was referred to her day hospital for an X-ray. Her X-ray showed a bony mass in the mid shaft of the right humerus, and this was complicated by a pathological fracture. She was subsequently referred to the orthopedics team at her district hospital, and a workup for a bony tumor, including metastatic disease, was initiated as shown above. An SPEP was ordered at this time. However, no urine or serum light chain testing was conducted at this stage, and the SPEP did not show monoclonal peak for her. The fracture was conservatively managed, and she was booked for an outpatient MRI. There was a 2-month interval between her initial orthopedics review and the MRI taking place. The MRI showed an aggressive mass within the right humeral diaphysis, and there was invasion into the surrounding soft tissue. The radiologist had noted a differential of osteosarcoma and a plasmacytoma on the reports. And shortly after her MRI was done, the biopsy was done, which confirmed a light chain restricted plasma cell neoplasm. Here's just a picture of her initial X-ray done at the day hospital. So just an important learning point in this case. So a light chain myeloma was missed on the SPEP, and plasmacytoma was potentially not considered as a differential of a bony tumor, and just illustrates again the point of overlying on single tests and diagnosis myeloma. And our third and final case is Mr. X. He's a 48-year-old male with multiple comorbidities. He was diagnosed with type 2 diabetes and hypertension about 10 years prior. Both were notably uncontrolled with target organ damage in the form of a previous hemorrhagic stroke. He had also been initiated on TLD in 2023 for HIV infection, but still had persistent low-level viremia with a CD4 of 230. Background social history and ongoing ethanol and tobacco use with about a 12-pack-year history. So he was initially brought to a secondary hospital emergency center by his family, who had noted mild confusion and strange behavior. He had a delirium workup initiated in the emergency center, revealed a creat of 300 with a previously normal baseline the year prior. His kidneys were large and no features of obstruction. He was then discharged from the EC after he was assessed by the team to be alert and lucid. We don't unfortunately have any access to the notes of this visit to establish what the follow-up plan was for him. He then represented to the same emergency center on the 1st of May. He had worsening confusion. We don't see a formal creat logged on the NHLS from this visit. However, at this point, a urine-free light chain was logged, but the sample was rejected due to an incorrect specimen being sent. He was admitted at that point by the internal medicine team for 5 days and discharged. We unfortunately don't see any clear note regarding the follow-up results or a repeat renal function made on the discharge summary. And then returned shortly after, the patient returned shortly after on the 14th to the EC again. He was treated for pneumonia. His repeat creats had climbed rapidly to 1,554. That's unfortunately seemingly not seen at the time before he was discharged from the emergency center. We don't see any repeat urine sample logged either, to suggest that the myeloma workup was repeated. His family then brought him back on the 22nd of May. He had worsening confusion. His creat had climbed to more than 2,000 with worsening uremic encephalopathy and oliguria. At this point, he was referred to the renal team for acute dialysis. And at that point, the full myeloma workup was initiated by the renal team. So this is just a picture of his serum-free light chain testing, which revealed a significant burden of light chain disease. Just a few learning points. In our last case, unfortunate case, it shows us that a delayed diagnosis is frequently multifactorial. And one important takeaway is that clinicians may often have a very low index of clinical suspicion in younger patients, especially if they're computing alternative diagnoses, as in the case with this gentleman. There's background of uncontrolled diabetes and hypertension, as well as possible differential for HIV-associated nephropathy. And the second learning point here is it's demonstrated a very common testing pitfall with rejection of urine-free light chain test samples that aren't noted or repeated in the tummies. And then just a note on the epidemiology of myeloma in Africa. So the prevalence of morbidity and mortality demonstrated in this review here on the slide demonstrated and highlights the need to better understand multiple myeloma and the diagnostic delay. And only with this understanding can we propose specific interventions that can be actioned on a grassroots level and a policy level to limit the devastating complications of this disease. And as we can see in these cases, the personal healthcare system as well as societal ramifications of a delayed diagnosis. The next slide here just shows a summation of the disease burden, the regional distribution, presentation and clinical severity, expected survival outcomes, HIV association, and drivers of poor outcomes amongst our patients in sub-Saharan Africa. So our patients in sub-Saharan Africa with myeloma, it's often underdiagnosed. Our patients present late. They have markedly worse survival outcomes. And this just reflects systemic diagnostic as well as treatment inequities in our region. So these factors in conjunction with poor access to the diagnostics and near treatment options, such as stem cell transplant, lead to overall poor outcomes for our patients. Just a forest plot here is illustrating again the 1-year overall survival of myeloma patients.
Thank you very much, Sinead. Last year I spoke at the same forum. At the time, there were provisional results on work we did at Groote Hospital, and I will review some of those results again and also present some further work that has since been done, but the work is not yet complete, of course. There's still a lot to do and a lot to understand. So I'll be presenting results on routine laboratory, blood, and confirmatory test patterns associated with delayed diagnoses. This is a conceptualization of models of pathways to treatment. And this is a very general construct, but has very relevant underpinnings in cancer, where there's initially a detection of bodily change. The patient then takes their symptoms to a healthcare provider where those changes are now interpreted by help seeking. And then the healthcare worker hopefully initiates some kind of diagnostic pathway that then culminates in a diagnosis and start of treatment. And the aim is, of course, to try and get better as quick as possible. So this is the basis of this investigation, and we are particularly interested in this diagnostic period where we as clinicians and healthcare professionals can hopefully make an impact. So these results are based on a study that we conducted here at Groote in Cape Town. We had consecutive patients who were referred with myeloma to our hematology center. As a reminder, Groote is one of two tertiary hospitals in the Western Cape. And we looked at their laboratory and facility encounter data in the 2 years prior to their diagnosis and referral. And these results included hemoglobin, creatinine, calcium, total protein, albumin, and confirmatory tests being in some form of a protein electrophoresis, either in the serum or the urine, or a free light chain quantification. During this study period, we included 150 patients that had results and medical records available. And this represented nearly 1,800 patient encounters with the public healthcare system in the 2 years preceding diagnosis. Unfortunately, we don't have any information from private healthcare visits, although these are also important, and it would be expected that patients may have sought help from private care, from also non-Western or non-Western medical practitioners as well. The median age was around 59 years. About half were female. Those who were HIV infected the prevalence was very similar to the background prevalence of HIV in our region. At least 72% had at least one other comorbidity, for example, hypertension, diabetes. Most were of a heavy chain subclass. And we noted that at diagnosis, about 15% had spinal cord compression, and at least 49% had a history of complaining of back pain. In the 2 years preceding diagnosis, there were on average around 10 visits per person, which kind of just shows that the patients were seeking help, but not necessarily getting to a diagnosis. And that's an unfortunate fault of the healthcare system, that we weren't able to help sooner. At these nearly 1,800 visits, so of those, all the visits, at least 43% had a HB checked creatinine, much fewer calcium and total protein. But you'll see then in the second column that the number of those tests that were abnormal were exceptionally high, especially for hemoglobin and creatinine, calcium, and there was also a significant gamma gap as well in those who were tested, who did receive a total protein test. These are Kaplan-Meier plots which show the time from the first diagnosis of anemia, kidney dysfunction, hypercalcemia, or an elevated total protein. And anemia was defined as per WHO criteria, kidney dysfunction above the upper reference, kidney function as well as calcium and protein above the upper limits laboratory reference range, and not by CRAB criteria. But you'll notice that many months before patients were eventually underwent testing, electrophoresis testing, the HB was already abnormal. The kidney function was already abnormal many months before. And it's only for calcium and a high total protein where the time is much shorter, but this probably just reflects that patients arrived much sicker and were therefore much more likely to have these tests requested later in their diagnostic pathway. These are now the diagnostic tests. So once someone who is suspected of having myeloma then undergoes some kind of confirmatory test, either in the serum or the urine, you'll see that most of the 150 patients that were in our study underwent a serum protein electrophoresis. Some, in fact, had no test at all, and the suspicion or the diagnosis was likely through a biopsy or something else, not through a protein electrophoresis. And of those who had protein electrophoresis, much less than had serum free light chain, and much fewer than as well urine protein electrophoresis. And just to highlight what the problem with all of this is that for patients who underwent serum protein electrophoresis, about 18 had their S-PEP repeated once. A few even had theirs repeated twice. Serum-free light chain were repeated in about 8 of the 87 that were done. And quite concerningly, those with urine protein electrophoresis, only a result was only available in about 81%, so about 3/4. And some had multiple urine protein electrophoresis repeated, probably because they were rejected. This table then illustrates or describes who was requesting these tests and where these tests were requested. And these, by tests, I mean some kind of protein electrophoresis or light chain quantification. So you'll notice that most were performed at a tertiary level of care during a admission, and mostly by internal medicine as the speciality. And the time from the diagnostic episode, so in other words, the final diagnostic episodes, in other words, this would be the admission during which myeloma was then diagnosed. That would be the final diagnostic episode. Some of these tests took up to 10 days or more to be done. So myeloma was certainly not considered early on during the admission, which then further delays treatment, especially if they already coming in with quite complicated disease, kidney dysfunction, etc. This is another Kaplan-Meier plot that shows the time from a test being performed, and you'll notice that some did not have any testing, so no electrophoresis, no serum-free light chain, but that was mostly just because patients only underwent testing when they were then referred to us. So at the time of our consultation or after we were consulted. And you'll notice that most patients underwent testing quite quickly, but some, in fact, waited many, many months. And in one case, a lady had come in with, unfortunately, I don't have the medical notes to get details, but she had a SPEP performed and then was admitted then many months later with something else, and had already had an SPEP, an abnormal SPEP, many months before that. So the conclusions that we can come to are that test selection and sequencing before diagnosis was often inconsistent. There was frequent duplication of tests, high rejection rates of urine samples, and this all culminates in diagnostic inefficiency. A high proportion underwent successive or simultaneous urine testing with the serum testing, but this is of likely little clinical utility, but instead just contributes to delay and inertia. Also, we can note that most patients underwent definitive testing very late in tertiary hospital admissions, likely when patients were already very sick, when the complications had already been established. And this was despite multiple prior healthcare encounters. And perhaps streamlining test requests, practices, prioritizing serum-based assays could potentially reduce some of these diagnostic delays and improve early detection. So to come back to the conceptual framework of the pathway to diagnosis and referral, we can see that there are issues with symptom recognition, firstly by the patient, although that's not studied here, but certainly probably by the healthcare worker for not interpreting the symptoms correctly. Or there are errors in test ordering and interpretation, and probably some system failures as well that should be addressed. And so I'll leave it here and ask that the audience also open the floor to the audience and see if anyone else has any high impact thoughts about how we can, as clinical and laboratory clinicians, try and help in some of these steps. I think I've stopped sharing. Thank you.
Thanks, guys, for such an enlightening and probing presentation. I think there's a lot that you said that may invite a lot of questions from the audience, and it's now open for people to ask questions or pass comments regarding this very important. I think myeloma is a huge topic and quite an important disease in our setting.
Honest. I just have a quick comment. This morning on the ward round, I remarked, and I really could establish that the quickest way for us to get a myeloma diagnosis in our setting is actually doing a marrow. And it's terrible that that is actually the test that's the fastest. So just want to know what other people think about that, because it can take a long time, and it's clear that people sort of lose, what's the word, sort of lose interest in the test results. I'd love to hear what others say.
Honest, can I make a comment? It's Jacques here from the Free State. So
Yes,
Yeah, I think thanks for that very important talk. And I think one of the things is that you highlight is that, or that I can just contribute, is that this is a problem throughout the country. We see exactly the same thing, long delays between important clues for suggesting myeloma. And I think what part of it is obviously the availability of the basic screening result or screening tests. And from our side here in the Free State, we don't have a problem with that. Any hospital or any doctor anywhere in the province can request the basic screening results. And I think if you want to go for gold, we should teach that when you request a SPEP, it comes as a package with the serum-free light chain. And I think if you do those two, there's very, very few myelomas that you'll miss. And if you add a urine light chain, you will pick up the majority of myelomas, except those very rare non-secretory or non-producing myelomas. I think the best way in which we can improve the pickup is to keep teaching these basic clinical pills of a raised protein gap. I mean, you've shown that, and we see it frequently. We've had patients with a 2-year history of a large protein gap before the first SPEP is done, and we see this very frequently. So we make sure we hammer this into our medical students. And so I think the diagnosis of myeloma, it's about thinking about general doctors, the junior doctors in the community, knowing about it and thinking about it. And the clinical pills of the raised protein gap, a presence of rouleau formation and a peripheral smear, and also the message that every single patient that is seen in a casualty or is admitted to a hospital must get a peripheral smear at least once. Interesting thing, that one that I have seen is the fact that a paraprotein is associated with false low vitamin B12 levels. And we've seen a few, well, thinking of one specific patient with a 6-month delay in diagnosis. He had a macrocytosis he had an anemia and a macrocytosis, a false macrocytosis due to the severe rouleau formation, and he had a low B12. And he was treated for 12 months with vitamin B12 with no response before somebody thought, maybe there's more going on. So we should, as a community that as a face with students, junior doctors, this should be hammered into them, because we see a lot of myeloma. I think myeloma is much more common in South Africa than the literature reports from Europe and those places. I mean, in the last month, we've had almost 2 myelomas a week, new diagnoses, young patients, 30 years old, and all of them have delayed diagnoses. And maybe to mention, additionally to that, obviously the warning signs of back pain should be a core knowledge for medical students, and actually even patient education. Some of our patients present late because they don't know what are the warning signs of back pain when they should seek help for that. So yeah, I think it's a grassroots thing that needs to be where the focus should be. And then obviously the support from the lab to ensure that these tests are broadly available and is done when requested. We should even make like a little poster of the clinical pills for early diagnosis of myeloma and distribute it to all the primary clinics in the country. Then we'll see the diagnosis much earlier.
We have one, Jacques, that we're working on.
I know. I think I was supposed to also contribute and comment, but don't think I
No, no stress. Yeah, it's actually almost complete.
Oh, great.
Okay, so there's a comment from Gary here that says, do you think this could advocate for adjusting reports generated by the NHLS laboratories to prompt the user to refer earlier? And how could this be done better? In your study, how often was the use of urine M protein noted?
As far as I'm aware, the National Chemical Pathology Consortium are actually working on standardizing the way SPEPs and serum-free light chains are interpreted for this exact reason, so that the output is much easier to interpret, and hopefully there's no ambiguity of what needs to happen next. And I think we saw some cases that Sinead presented that, yes, it gives all the information, but it says things like there's a suspicious band, and then immunofixation is done, and I think the pathologist will often say that it's the clinician that needs to then interpret those results. But as we know, I'm not a smart clinician, and I need help from the pathologists to understand what those results mean. And perhaps we can make it clearer for the clinician with messaging from the pathologists and their reports.
And in your study, just for me, did you try to identify why there was a lot of urine test rejections? That is the first one. And the second one, the fact that most tests were performed at a tertiary center, is it a matter of lack of knowledge in the smaller hospitals, smaller centers, or lack of resources to do the tests? Did you try to get into that?
The urines are often rejected either because the specimen leaks, it's mislabeled, and of course the additive is not, the sample isn't included with the additive that it's meant to that's meant to go with it. As far as I understand, speaking to pathology colleagues, hopefully that assay is going to change, as I understand, and soon the additive will no longer be mandatory. So hopefully there will be less rejections because we won't need the additive anymore. So yeah, that's why it was rejected. As Jacques said, these tests are not gate kept. So any primary healthcare clinician could actually request them. I think it's mostly a case of when recognizing when these tests should be done. And that will go a long way.
And one more from my side on the comorbidity burden. How does our data here compare to the worldwide? And besides the high HIV prevalence, is there anything else that separates us from the rest of the world?
I think, and Jacques has made this point that it's probably just that we're under recognizing myeloma rather than there being any biological reason or any other. It's probably a system failure rather than anything else. I see Fiona also suggests that and this would be nice where you could automate a message that either goes to the patient to follow up their own results. And I guess that would be nice to put the patient at the center of their own health and put their responsibility of finding out the results themselves. I know it would be nice as well to call out results by the lab, but often the lab doesn't have the capacity, and clinicians write illegibly, and they don't even add phone numbers onto the requesting form. So it becomes very difficult to close the loop between clinicians and the lab when results are not normal.
Let's just go to the.
Can I
Yes.
butt in with the three comments? So in private, I mean, we obviously suffer from actually both over and under diagnosis. I mean, we sometimes see patients who've gone through the same long procedure, so it's not necessarily a fault of the 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 state healthcare system, although the structure obviously leads that to happen more commonly. But we sometimes see patients in private I mean, I've seen patients who've been on dialysis for 2 years before the penny drops. That hang on, maybe we haven't tested for myeloma yet, and then that's kind of rather late down the line. But conversely, we also see hundreds of GPs who feel that a SPEP is part of a routine yearly screening bloods, and then the amount of MGUSs that we get flooded with. There's actually quite a lot of them. So we've got a lot of MGUSs on our books. So it's both a sort of paradoxical, to some people too late and some people way too early. And then a comment to Jock about the incidents. I mean, yes, I also feel like we're flooded with myeloma. Some days, I think half of my clinic is a myeloma clinic in private. I mean, obviously, we're doing better at keeping them alive, and they stick around for a long time, and they're on long-term therapy, obviously, which is different from many lymphomas. So you do tend to see them more often, but it just kind of is an issue. But I think the real problem is that one of the things we really are doing quite badly is that the National Cancer Registry, which is primarily a pathology-based registry, is not capturing all the myelomas, which it can obviously is a clinical pathological diagnosis. So, there's sometimes not commonly making without necessarily a sort of a histological sample. So I think we think the National Cancer Registry is definitely under capturing the amount of the incidence of myeloma in South Africa. So when we're wanting to do clinical trials and people ask how many myelomas have you got, I mean, yeah, I can tell you how many myelomas in the clinic, but I can't tell you what the incidence is in South Africa because that's often what they're looking for. So it's a real problem in terms of capturing that data. And then, I mean, I think that just in terms of incidence in blacks, I mean, I think the incidence of African Americans is definitely higher than that of white Americans. That we've got good data for. So there's definitely a genetic component, which is obviously multifactorial. I've just heard of one of Paul Richardson's, who's from the Dana-Farber, one of his latest kind of hypotheses that Duffy null status has something to do with the incidence of myeloma, in that the Duffy null red cells are less able to absorb cytokines, and there's more ongoing chronic inflammation, and maybe that's also driving myeloma in black people. So that's a very interesting hypothesis that I think there's a lot of work obviously to be done there, but it's one of the things, because we obviously also got, I mean, since areas of the country, 60% of the black population has got Duffy null status. So it's very interesting. So the HIV guys have done a lot of work. I mean, there doesn't seem to be anything between HIV and Duffy null. There's no worse outcomes in HIV situation, but obviously it's a provocative hypothesis that needs to be looked at in terms of myeloma. Thank you.
Okay,
on the registry, I think some work has been done looking at cancer and myeloma diagnoses in some Johannesburg hospitals, and then comparing those to what is captured by the cancer registry, and it's taking a bit of time. But we also here at Groote are also trying to validate or compare the cases that are reported to the cancer registry from our own hospital, and to understand if the registry is capturing all the patients that we have, and vice versa, how many are being captured by the registry that we are missing. So that work is underway and important as well.
all right, thanks. There's a comment from Dr. Philip. I think it's a very important one. Which says any patient 50 years old with back pain and anemia should be investigated for myeloma. I think that's quite important. And I think Jacques talked about delays from the patient sides, young patients that presented late, that kept attributing the back pain to mechanical reasons. And again, another important one, I think for the lab as well, or when we request, automatic immunofixation is done on any abnormal SPEP. Because I know some labs, if you just request SPEP, they won't do immunofixation if you haven't requested it. And I think it is an important suggestion that any abnormal SPEP must be followed by immunofixation to identify the abnormal M protein. And then, yeah, the other comment that Jack made here, which is, I think, very, very important as well, is in order to make diagnosis easier for primary or secondary healthcare centers, it feels that we should not recommend 24-hour urine, but rather do a spot one, and then the 24-hour urine can always be done at a higher center. I think that will definitely increase the pickup rate for the myelomas that are being missed. And again, another comment from Jack that says, I truly think that we have much higher incidence of myeloma. There must be some biological basis for it. And he queries the impact of HIV, which is probably what is increasing the incidence of myeloma in the African population. And then Martinez Dick says, I think it is important that the coding at the end of the Maro report be done correctly and consistently across centers to aid data capture. Very important as well, the ICD codes, especially in private practice, if they are not well coordinated, it may give a false impression as well. And Dr. Naidu's comment says, I routinely review all old results of my patients at first consult in private, and note that tests like total protein, globulin levels, calcium, magnesium, phosphate, UNE, FBC with Rollo can identify a problem much earlier. Patients are usually shocked with this review. The alternative, more worrying when an active academic with 3 times spontaneous rib fractures over a year feels that this normal plus self-treat and only presented when they had difficulty walking. And then another comment from Jack again, which says we should look at the definite prevalence in our myeloma population versus the non-myeloma population. And Garrick says Sunbus should have that data if they do red cell antigen screening in patients with myeloma who receive transfusions. I wonder if it forms part of their routine panel of antigens. I don't know if there's anyone from Sunbus who can allude to that. And if there's someone else with a question or comment, you may unmute yourself and then just ask a comment.
Honest, I think that Andrew has some of that data. Can you hear me?
Yeah. Yes, yes.
So I think Andrew is the one who knows more about the Duffy phenotype than any of us. So perhaps he can answer that. I think there's a few simpler things we can do. And for example, we can start understanding our tests better. I agree. In our center, we should actually focus on a serum-free light chains. That was the decision made many, many years ago. Your chance of missing a myeloma by doing serum-free light chains in place of a urine is minuscule. So do the serum-free light chain, unless in your center, it takes much longer for the result to come out. So I think we must all kind of make sure that we know the time for tests to come back in our specific setting. That's why I'm saying in our center, doing a marrow can be the fastest way of getting a diagnosis. That's actually shocking, but that is so because it often takes at least a week for these results to come back. So SPEP and serum-free light chains, like Jacques also agrees, is the best way to go. We don't have to do all these urines. And I know I'm very shocking, but we never, ever, ever, ever do a 24-hour urine in our clinic. Never. In fact, I think it's actually a crime against humanity to do it in Africa because you can get more or less the same result with a spot urine if you want to follow, or with a free light chain. So to have people that are already struggling with transport and with money and with going to work, to have them have a 24-hour, I do not think it's a good idea. I will keep saying it. It's the minuscule change between shaking up a 24-hour urine and taking a spot test is so minuscule that our pathologists are quite happy to do that. They simply work it out as a 2-hour type of urine. So I think there's so many cool things we can do, and there is so many good ideas that came. I think, Nicola, we must print out the chat box and see if we can do something with some of these ideas or write them down. So I think it's great ideas and great plans.
Honest, maybe just to add to that comment from Estella, I mean, I think I agree with the general utility of a 24-hour urine, but I think just for the trainees, there are some situations where a 24-hour urine is needed. One example is where you are thinking about a monoclonal gammopathy of renal significance, where there's no other myeloma defining events, but the patient's got renal failure, but other potential causes of the renal failure. Obviously, the best way is a kidney biopsy, but that's not always possible if the kidneys are small. And it is sort of mentioned that if you have a 24-hour excretion of light chains over 500 milligrams in 24 hours, it's highly likely that the renal dysfunction is due to the underlying monoclonal gammopathy. So I think it's important that the trainees just know that. And then another place where, but again, you could probably get away with just the spot, is that if you're using and it's interesting, this is not written in any book that I've seen, but this was told to us by the experts when we had that myeloma workshop in Johannesburg early last year, where all the experts were. So they say that if you using the serum free light chain ratio in the slim crab, that uninvolved ratio of more than 100 as your only indication that this is myeloma, this is only valid in the setting where there is Bench Jones urea. And they specifically mentioned there are some cases where for some reason they do not filter the light chains, and then that you cannot use that slim the light chain criteria in the slim crab. So those are the two places where the light chains are absolutely, or the urine light chains are critical.
So there's also a suggestion of an algorithm for primary healthcare practitioners, or a clinical prediction score, or a calculator that can be used to suggest the presence of myeloma and probably tailor the investigations to prove the diagnosis. And Garrick asked a question here to Andrew: how many of your MGAS patients actually have associated disease like renal or neurological abnormalities?
I can maybe just comment there from our side, is that it's a very frequent referral from nephrology to us. Patients worked up for renal failure and found in monoclonal band and uncertainty of the underlying core etiology of the renal disease, usually when they can't do a biopsy. And it can become very challenging sometimes to decide, is this a monoclonal gammopathy of renal significance or just the MGUS with some other cause of renal failure? And sometimes, it can be quite tricky to make the final call if you're unable to do a biopsy.
Any other questions and comments? I think Andrew has answered Garrick there that there are not many. There are few with peripheral neuropathy, very difficult to decide whether to treat or not. Probably other causes to be investigated there. I can't see any other comments or questions or any hands that are up. But I think it has actually stimulated quite a good debate and suggestions on how to improve, the diagnostic pathway in myeloma and to try to streamline the care of these patients so that they are treated early. And obviously that helps to improve the outcomes of these patients.
Renani just had his hand up. Renani, if you want to go ahead and unmute and ask your question.
Yes.
Okay, thank you. Thank you. Vunani Kondo from Tata, another part of South Africa, if I can put it that way. We had our myeloma symposium last week. It was very indeed. Thank you for Blood SA for also advertising it. Various points that were highlighted. Special patients were coming from our orthopedic surgeons. History is not properly taken. They just go fix the bone and leave patient, and then 5 months later or so, you then realize SPEP was never done, if just as an ESR was never done, kind of thing. Therefore, that was our major challenge. Another thing that we noted from us, in our center, we don't even have an SPEP, a chemical pathologist that can do an SPEP. Therefore, we have to send our SPEPs to Johannesburg, which makes life kind of difficult for the diagnosis, even at the tertiary level, and then also for the monitoring of these patients, because our SPEP in Nelson Mandela can take to about a month or so. Therefore, it's quite difficult. Those are the 2 points that we were really struggling to currently, even just to get a plain MRI can be very difficult here. Therefore, we are still trying by all means, but we're hoping we'll get there one day.
Thanks for that very important observation. Obviously, part of a system failure, but I'm sure we can, try to do as much as we can. Following up the results, they may take long, but I think following them up probably will also help 1 or 2 patients. I think Dr. Gutta says, thank you for the suggestions. We try to implement some to improve early diagnosis in Zimbabwe. And another comment from Jacques says, radiology delays is a huge problem in the public sector. So yeah, there are quite a number of system challenges that we have to grapple with in the private sector, in the public sector. It may not be a huge problem in the private sector, but I think we should, as clinicians, just keep trying other ways of trying to get to the diagnosis early to try to help the patients. I'm not sure if there are any other questions or comments. I don't see anything in the chat box or any hands up. So otherwise, in the absence of any further questions or suggestions, I would like to thank the presenters for a wonderful job, opening our minds and eyes to these challenges that we face every day. And otherwise, wish you a good night and see you next week.